Hello everybody, welcome to BD Nurse e-Corner channel. In this video, we are going to see the scenarios which we come across, especially patients with all the electrolyte problems and might be in an ICU, in an OT or might be in an emergency room. So being a nurse, we have to get prepared on what to be done and how to analyze a patient with potassium imbalances. So let's move on to the introduction. So coming to the introductory part, we all know that potassium is a very important component and mineral which is playing a vital role majorly to signalize the nerve impulses, to do the muscular contractions as well as to maintain the normal heart rhythm. So if this level is being maintained in the serum, especially in the bloodstream, when we give a range of 3.5 to 5 milliequivalents per liter, then we call that the patient is said to be normal. But if the potassium level is deviating in the bloodstream, either it is going less than 3.5 milliequivalent per deciliter, or might be if it is going more than 5 milliequivalent per liter, then we call this condition as potassium imbalances, or in other terms we call it as hypokalemia or hyponatremia. So we are going to see in a comparative stage for better understanding. So what is hypokalemia and hyperkalemia? So hypokalemia is a patient who is going to have the potassium level of less than 3.5, whereas hyperkalemia where the patient is going to have the potassium level in the blood more than 5.5 milliequivalent per liter. So in this, the predominant symptoms, the patient who are going to expose in the emergency room or might be in the OT. So you can divide this into system-wise symptoms, the patient who are going to predict externally. As well as some you can monitor through the monitor itself. So here, starting from the cardiovascular, respiratory, neuromuscular and gastrointestinal, you can have a comparative picture. That is, on one side you have hypokalemia, on the other side, that is on the right side of the monitor, you can see that you are having all the symptoms of a hyperkalemia patient. So the first symptom is the patient is going to have weak, thready pulse, irregular pulse in case of hypokalemia, and it is opposite, that is slow, irregular pulse in case of hyperkalemia. Here the patient is going to have orthostatic hypotension, that is as soon as change in the position might be from supine to full sitting position or might be standing position, the patient BP is dropping down, or might be generally whether it is on supine or might be in a prone or in a standing position or sitting position. In all the three types, sitting, standing and lying down BP, the patient is having low BP in case of hyperkalemia. Coming to the respiratory symptom, the patient shows shallow as well as very much ineffective respiration as the skeletal muscles are very weak due to the reduced potassium level in the blood, hence the stimulation is less. On the other hand, you can see the patient is going to have profound weakness in skeletal muscles which can lead to respiratory failure. In case of a hypokalemia, the patient is going to have neuromuscular symptoms such as anxiety, skeletal muscle weakness, leg cramps, and some of the patients may be coming and complaining of might be paresthesia, that is tingling sensation or numbness around the extremities, and deep tendon reflexes are very much reduced. Whereas in case of a neuromuscular problem in hyperkalemia, there you can divide into early and late symptom, where in the early symptom patients are having the same symptoms such as of hypokalemia, that is muscle twitching, cramps and paresthesia, whereas in the late symptom you can see the patient is ending up with flaccid paralysis, that is total loss of the function of the arm, might be motor or sensory in the both upper and lower extremity when the potassium levels are going very much elevated. In case of the GI symptom, you can see there is gut motility is very much reduced in hypokalemia, and you can on auscultation you're going to have very much reduced bowel sounds, And of course, the patient is going to exhibit certain symptoms of nausea, vomiting, and some patients are having constipation, might be, which is leading to paralytic ELEs. And on the other hand, you can see the patient is going to have increased motility, so that is giving a gut symptom, that is due to the hyperactive of the bowel. The patient is going to have increased hyperactive bowel sounds. The peristalsis is high on all the four quadrants upon auscultation, and of course here patient is having diarrhea due to the increased peristaltic movement. Next, not wasting the time, we are moving on to the ECG changes with potassium imbalances. So I want to explain with the normal ECG when compared to the abnormal. So when you take the normal ECG, you have a P wave, yes, where you have the positive deflection. Then there is a small negative deflection, the Q wave. Followed by that, you have the R wave, which is very much peak onto the top, which is a positive deflection again. Then you have a T wave very close to the isometric line. Then you have a positive deflection, that is the R and the T wave, followed by the U wave. So normally the P wave always is in the positive deflection. The PR interval must be very much, it should not be very narrow or wide, and the QRS complex is very much normal, as well as you can see the round size T wave followed by the U wave. This ECG, the first one, we call it as the normokalemia, that is the potassium levels are well maintained between the levels of 3.5 to 5.5 milliequivalent per liter. On the other hand, you can see the other two comparative ECGs, that is hypo and hyperkalemia. So in case of hypokalemia, you can see the P wave is slightly peaked away from the normal isoelectric line. So it is slightly away from the isoelectric line. And there is a long, or you call it as a prolonged PR interval, followed by a shallow T wave which is not round, and there is a prominent U wave. Now the U wave is representing like a T wave. So when you see, that is the P wave is slightly peaked, there is a wide PR interval, followed by the U wave representing like the T, and you can see there is a depression in the ST segment, which shows that the patient is having reduced level of potassium. On the other hand, you can see the lower ECG, which is stating that the patient is having hyperkalemia. So here it's just the opposite, that is, in case of hypokalemia, the P wave is peaked, whereas in case of hyperkalemia, when the potassium is high, you can see there is a wide and a flat P wave. Followed by that, you have the decreased amplitude of the R wave. In a normokalemia, it is highly elevated. You can see the positive deflection. The positive deflection is very well good. But in case of a hyperkalemia, the QRS, that is the R wave, you can see it is very much little. The amplitude, the wavelength of the amplitude is very less. Followed by that, you have a wide QRS, that is the Q and the R and the S, that gap is very much wide, and there is a very much depression, that is ST segment getting depressed, and you can see followed by a tall and peak T wave. So blindly you can keep it in mind that when there is a peak T wave, or might be the P wave is flat with a wide QRS complex, and the R wave is amplitude is reduced, which shows that the potassium level is very much increased in the bloodstream. So after discovering what is happening with the ECG changes, who are the persons who can develop this is that, especially potassium, in case of hypokalemia, there is a loss from the body. So might be there is inadequate food intake by the patient, either by fasting or nil per oral due to any of the procedures or disease conditions. And might be the patient is having heavy potassium loss such as heavy diarrhea, or might be due to hyperinsulin or due to alkalosis condition, or in case if the patient is being received with dilution of IV therapies with potassium deficient solutions and water intoxication when they are having more than 5 liters or 4 liters of water where the body is developing water intoxication syndrome. And on the other hand, hyperkalemia may result up with due to certain drugs such as AC inhibitors, NSAIDs, and potassium sparing diuretics. Might be some patients who are having excessive dietary intake of potassium, or might be in case of a renal or cases who are undergoing dialysis. And certain disease condition also may lead to hyperkalemia such as Addison's disease or any tissue damage such as burns, acidosis and hyperuricemia or any sort of hypercatabolism. So coming to the management, so being the nurse, whether it is hypo or hyper, both are treated very much separately and some are like it's overlapping, you will be coming across. So in case of a hypokalemia, when the potassium level is reduced, you're going to pump in or you're going to infuse the potassium, and it is the opposite. When the potassium level is high, you're trying to remove it from the intracellular spaces or might be from the tissues. So what we're going to do as a nurse? One, you can do is that in case of hypokalemia, start with potassium supplements, liquids, potassium chloride, potassium retaining diuretics, which such as spironolactone can be started, but keep in mind that never ever start the administration either directly IM, IV or subcutaneous. It is always being diluted with some amount of, especially 100 ml of NS, and then you're going to give it through infusion, might be 5 ml per hour or 3 ml per hour according to the patient's weight. We do the calculation and then we start with the infusion. And on the other hand, you can see the patients who are having due to hyperkalemia, you are going to start with continuous monitoring of EKG, or you call it as ECG, and then start with restricted diets of potassium, avoid all the salt substitutes, as well as you're going to discontinue any sort of potassium when the patient is receiving either through per oral or IV. Just get the whole drug from the physician and then immediately start with potassium secreting or sparing diuretics, and then you start with dialysis in severe cases, or you can plan with the IV infusion of calcium gluconate or sodium bicarbonate. So the major foods which are rich in potassium is that avocado, banana, and carrots, fishes, oranges, potatoes, beef, pork, spinach and tomatoes. Potassium and sodium are opposites. So in case of potassium high, you can see the sodium level is decreasing, or in case of sodium level is high, the potassium level is decreasing. So along with potassium, you have to treat the sodium, and in case of hypo or hypernatremia, the same thing will be done, that is potassium is also being treated. So last but not the least, you're going to see some of the supplements which we give. So this picture is denoting it is a potassium chloride, which in case of hypokalemia we can give, and spironolactone drugs can be given. In case of a hyperkalemia, you're going to start with infusion such as calcium gluconate, or you can start with infusion dilution with 100 ml and then give slow IV according to the weight of the patient. Soda bicarb can be started, or in severe cases plan for dialysis. So to conclude, potassium might seem like just a mineral, but it is very important to keep the body to run smoothly. So either if it is too low or too high, the heart rhythms are going to get altered and it is going to create the risky of the patient's heart. So hence regular monitoring, proper diet and using of safe medications are very much important. And as a nurse, we have to be very alert on how to analyze whether the patient is having hyper or hypokalemia, just by looking onto the ECG or might be looking onto the patient's symptoms, and then take a blood serum workout, and then you can immediately start on with the emergency management, as this, if it is untreated, may go to life-threatening situations. And that's all for today. And if you have any doubts or queries, don't forget to put onto the comments section. Thank you for your patient listening. Thank you all.